You may have seen a lot of this stuff. I doubt you've seen this before. Because I put this together about a year ago, and it struck me ever since. There are two big studies out there that have tried to take the big picture about lifestyle behaviors and clinical behaviors and what we should be doing. One of them is the actual causes of death study. Came out of CDC. I'm sure you've seen it. Suggested if we could affect those three behaviors, smoking, physical activity, and eating to maintain a healthy weight, and get everybody to do the right thing, we could save about 800,000 lives a year in this country. And the clinical behaviors is a group called the National Commission on Prevention Priorities. They were commissioned by CDC. And they said if we affected the behaviors I just talked to you about, screening for chronic diseases and immunization, we could save about 79,000 deaths a year if we got everybody to do those. And, 79,000 deaths a year, is that a big deal? It's a very big deal. I mean, it's more than we could do if we could eliminate all car crash deaths magically. It's more than we could do if we could eliminate all homicides magically. So it's a big deal. But look at it compared to those three lifestyle behaviors. They're not even, frankly, in the same league. The order of magnitude is demonstrably different. So if we're going to make a difference in our employees' behaviors, in our employees' health, really we need to do the clinical behaviors, and I'll talk about that, but we also really have to deal with this lifestyle stuff. So behaviors that save money. I feel the need to talk about this because I think we oversell prevention, and I think it's a mistake that we make. We do it to ourselves, we do it to policymakers. When the National Commission on Prevention Priorities looked at all of the things for preventing chronic diseases, they found only 3 behaviors that save money or are break-even, and they're up here. So it's colon cancer screening, flu vaccination, and smoking cessation treatment. And you may say to me, wait a minute, are you telling me it's not cheaper to treat a woman with breast cancer early than it is late? Well, of course it's cheaper to treat a woman who has breast cancer early than it is late. But it costs us a lot to find that woman. If the incidence of if only 1 in 8 women or 1 in 9 women get breast cancer in their lives, and only 1 in 3 or maybe 1 in 4 women who have mammograms benefit from that in terms of saving their lives, you do the arithmetic and you find out we have to screen 25 or 30 women in order to actually make a difference in one woman's life, and we have to do it every year after the age of 40 or every 1 to 2 years. And you can see why the costs of that actually outweigh the benefits of it. So should we be doing it? Absolutely. I mean, it's great money. It's some of the best money we spend in healthcare. We spend money in healthcare on many stupid things. And so this is a great chance to save women's lives, and it doesn't cost us very much, but it doesn't save money. And we shouldn't kid ourselves that it saves money, and we shouldn't tell others that it saves money. And then you look at these 3 things, and we do really badly on these things. Here are 3 chances to either break even or save money: colon cancer screening, flu vaccination, smoking cessation treatment, and we're not doing very well. So how badly are we doing? Well, these are data from the Behavioral Risk Factors Surveillance System for people in Washington State who have jobs and have health insurance. So that's us up there. I mean, I'm one of you. I'm a Washington State employee from the University of Washington, and we're all represented in that slide, and the people that we work with are represented pretty well in that slide. And you can see that over the age of 50, the group for which for a decade now we've recommended annual flu shots, 7 out of 10 of us don't get it every year, or haven't had one in the past year. 6 out of 10 are overweight or obese among this more privileged group. About half are not up to date on colon cancer screening. About 4 out of 10 don't get enough physical activity. And even today, even in this state where we have one of the best tobacco control programs in the country, still 1 out of 6 of us smoke. So we've got plenty of work to do. We're not going to run out of business anytime soon. And we see that that risk behaviors are not equal opportunity. You know this, but just to make this really clear, again, this is people who have jobs and have health insurance. We've already selected down to a privileged population within our state, and yet the socioeconomic differences are dramatic. This is just one example, but I could show you this for a lot of different things. that if you make less than $25,000 a year and have a job and have health insurance, you're more than twice as likely to smoke as if you make $75,000 a year. And the prevalence is really quite high among folks at the lower end of the income scale. So when we think about what we're going to do on a lot of these behaviors, we need to be thinking about our lowest income workers mostly. I would argue most heavily, because they're at greatest risk. Lowest income, lowest education. So how can employers help? Well, we've talked about the chronic diseases and we've talked about the behaviors, so let's go on and talk about the meat of this, which is what we can do. And I'm mostly going to describe evidence from CDC's Guide to Community Preventive Services. That is an effort that is now about 15 years old, actually, at CDC. There were a group of us who said, you know, we've been doing this on the clinical side forever. You know, we've been doing it for 25 years to say what works. We haven't done it for community-based programs, including things in the workplace. Let's actually go out and look at the literature and let public health workers know what actually works. And so we did it. And in tobacco, sometimes we had to review 10,000 articles to make one recommendation. So this was expensive work. And what I'm going to try to do is boil down for you the stuff that is relevant for the workplace. And again, this is, you know, I love this stuff. I mean, I devoted a fair bit of my career to it. So you have to don't take it with a grain of salt. I think it's true, but know that I think it's good stuff, because it is what I used to do. You know, I think if we're going to do a bit of stuff, I think sometimes we have to think different, as they say in Apple land, and we have to kind of go back to basic principles and think about the logic of what we're doing, though. So let me ask you, what happens when we raise the price of something? What happens to the quantity consumed? This is basic microeconomics, but what happens if you raise the price? What happens? The consumption goes down. How about in healthcare? The good example of that is gas. You know, it turns out I brought a friend down. This is my second trip to Olympia this week. I brought a friend from the park and ride. She made her husband drop her off because she said she'd never find a parking place at the park and ride. Well, that was 3 months ago. Now she has no trouble finding a place in the park and ride because gasoline's gone down to $2 a gallon. So there's room in the park and ride again. What about in healthcare? Does it make a difference if the people, are they affected by cost? Well, they actually absolutely are affected by cost. They're affected by the cost that they see when it's the cost that we present to them. They're not affected by the cost that they don't see, but they're affected by what we tell them, by what we not tell them, but deliver to them. And copays are one of the major ways in which we deliver cost to people on a procedure-by-procedure basis. And so a $5 copay actually turns out, especially for a low-income woman, to make a big difference in whether or not she uses mammography. So copays, I wouldn't want to rail against copays. We do a lot of unnecessary things in healthcare in the U.S., and making people think twice about those things is a reasonable thing. But do we want people to think twice before they have a mammogram? I don't think so. I mean, do we want people to think twice before they take their blood pressure medicines, before they fill a prescription? I don't think so. We've been using the one-size-fits-all approach when it comes to cost. And again, I know you don't have a lot of control over this, but collectively, I think you might have control over it, and I think it's a point that's worth understanding. And it applies to a lot of things in terms of barriers. So how can employers help? Well, the three things I've talked about. Let's make it easy by removing the barriers. You know, people talk a lot about incentives and about wanting to pay people to be healthier. We may get to that, although the literature's pretty mixed on that. But it's clear that mostly we put roadblocks again and again in front of people. And when we've removed all the roadblocks, then let's talk about incentives. I mean, those are disincentives, but I mean in terms of paying people. Second thing is the notion of making it popular by making it seem like it's the thing that everybody does. And the third is by giving people, you know, we're not born knowing how to eat healthy. If we were, we wouldn't all look like we do. We're not born knowing how to exercise in our card-driven culture, obviously. And there are little micro practices, micro things that we can do to help people do better in this.